Hello, hello. Okay, welcome to another lesson where we are looking at tetanus neonatorum. As usual, I'm your presenter. My name is Jones. Okay, so let's define neonatal tetanus neonatorum. So by definition, it is an acute toxic illness that is caused by soluble exotoxin tetanus plasmin. The toxin is produced by the vegetative form of the bacilli. The cause is Clostridium tetani, which is an anaerobic gram-positive, non-encapsulated motor rod. The terminal spores resemble gum sticks, and spores are resistant to various chemical agents, including boiling, but are destroyed by autoclaving. So we're saying the spores are resistant to boiling, but they can be destroyed by autoclaving. They are found in house dust, soil, salt, fresh water, cow dung, and pig feces. Tetanus bacilli are not invasive, but produce two toxins, tetanus plasmin and tetanolysin. Tetanus plasmin is neurotoxic and is responsible for all the signs and symptoms of the disease. It is only second to botulism toxin as the most poisonous toxin. Tetanolysin, on the other hand, causes hemolysis of red blood cells in utero. Let's now look at the epidemiology of neonatal tetanus neonatorum. Tetanus occurs all over the world and high in developing countries. It is a major cause of neonatal mortality. The mortality rate is about 60 to 80% in Zambia. Increased incidence occurs among neonates born in villages and compounds where there is dust. It occurs where people handle and use dirty knives during delivery to cut the umbilical cord and dirty linen used during delivery. Okay, so now let's look at the customs and traditions that are also contributing to tetanus neonatorum. The use of cow dung on the umbilical cord may introduce the bacteria to the site, and hence the baby may die of neonatal tetanus. Bathing a newborn baby in African medicine, because the African medicine has been contact with the ground, may also introduce the infection through the open skin of the body to the baby. Okay, so these are some of the customs and traditions that are also contributing to the presence of neonatal tetanus. Let's look at the incidence. Both sexes are affected equally, and the incubation period of the disease is 1 to 7 days. Let us now look at the pathology of the disease. Okay, transmission occurs through a punctured wound or umbilicus that is contaminated by soil or dust, or animal excreta contaminated with Clostridium tetani. The infection is localized with minimal reaction. The infection then enters through a puncture or open wound, the umbilicus for example, into the body, and it causes local infection and tissue necrosis. It also produces toxins that enter the bloodstream and lymphatics, and eventually this spreads the central nervous system and produces clinical manifestation of the disease. What has to be borne in mind here is that it's the neurotoxins that gain access to the blood and the lymphatics, causing systematic signs and symptoms. When the conditions are favorable, such as dirty wounds, the organism will proliferate and release a potent exotoxin that affects the CNS to produce clinical manifestation of the disease. The toxins then become fixed on the nerve cells of the anterior horn of the spinal cord and the brainstem. The toxins will act on the neural junction to produce muscular stiffness and lower threshold for reflex excitability. Okay, that is all on the pathology of the disease. Now we can look at the clinical features that are seen in neonatal treatments. So, one of the clinical features that we can see is difficulties in sucking due to spasms of the masseter muscles. The baby is going to have difficulties in sucking. There is also what we call trismus or locked jaw that we also see as one of the signs and symptoms in neonatal tetanus. There can be stiffness of the muscles of the neck. There can be difficulties in swallowing due to spasms. There can also be spasms of facial muscles that produce a fixed sardonic grin, which we call rhesus sardonicus. Tonic contraction of all muscles may also be seen in the patient, and patient may start having convulsions. Lumbar and abdominal muscles become more rigid in this condition. It becomes one of the signs and symptoms that we see. The patient may also assume what we call an obstructinous posture, which is an extended neck due to contraction of the neck muscles. Spasms of laryngeal and respiratory muscles may lead to respiration obstruction and respiratory arrests. Urinary retention and anuria due to spasms of the urinary bladder or sphincter is one of those signs and symptoms that can be noted. Fever with temperature going up to 40 degrees is also one of those things that is seen within this condition. Alright, so other signs and symptoms may constitute hypertension, tachycardia, and cardiac arrhythmias. They may be present due to autonomic dysfunction. The peak of signs and symptoms are between 4 to 7 days and may stop spontaneously if the patient has not died of cardiac arrest and respiratory failure. Spasms may be precipitated by light, noise, and touch as stimulus. Hence, that's the reason why we miss this patient in a very quiet room with a dark, little bit of dark environment, not too light environments. Let's look now at the diagnosis of neonatal tetanus. It is based on clinical grounds, that is, history of patients, trismus, body spasms or stiffness, obstructiveness or difficulties in swallowing. So mostly diagnosis is based on these cardinal clinical features of tetanus. Otherwise, the bodily findings on ECG are non-specific, but they are done to just evaluate cardiovascular involvement. Other differential diagnosis that can be done is to rule out poliomyelitis. So poliomyelitis may be present with spasms and stiffness in the early part of the disease. However, trismus is absent in poliomyelitis. So polio may present itself more like in neonatal tetanus. The other disease that may also present itself in a similar way is rabies. So you have to rule out history of being bitten by a dog. Then the other disease is tetany. Let us now look at the complications of neonatal tetanus. So the first complication is pneumothorax, malnutrition and dehydration, because the patient is not feeding, emphysema, atelectasis, and aspiration pneumonia. Let's now treat this condition. Our objective of treatment is to remove the source of tetanus spasm. We have to neutralize the circulating toxins. We have to promote supportive care until tetanus spasm, which is fixed to the neural tissue, is metabolized. So there is an immunoglobulin known as tetanus immunoglobulin, which is given, that is 3,000 to 6,000 international units IM to help neutralize the tetanospasmin. In absence of tetanospasmin immunoglobulin, tetanus antitoxin, 50,000 to 100,000 international units intramuscularly can be given in 2 divided doses. You can clean the cord with hydrogen peroxide to help the cord to heal and kill the local bacteria on the area. Antibiotics such as benzyl penicillin, 200,000 international units per kg body weight, can be given 4 times a day for about 7 days to help lessen on the bacterial load. Tetracycline, 30 to 40 milligrams per kg body weight, QID, is also one of those drugs that can be given but mostly indicated for adults, since in children it may cause the teeth to start coloring or become dented. They start having a strange color. So tuberculin and other muscle relaxants can be used, but due to respiratory paralysis, artificial ventilations can be used. In case of the convulsions, 0.1 milligrams per kg body weight can be given of Valium for the spasms and the fits. Tracheostomy may be done to help aid breathing in these patients. Let us now look at the prognosis. The prognosis of this disease is that neonatal mortality is about 60 to 80%. The chances of survival when the patient has been diagnosed with the disease are quite few, that is 60 to 80%. Alright, so now with that said, let us now look at the nursing care of our client with neonatal tetanus. Okay, so let us look at the environment or the room in which we are going to nurse this patient. We have to admit the child in a neonatal intensive care unit and isolate to a side ward. We have to nurse in an incubator or cold beds to prevent hypothermia, and a constant environmental temperature will be maintained for you to ensure that the child does not have hypothermia. You can nurse the child in a quite dark room to avoid spasm. There should be minimum interference from the nurse as she carries out procedures. Hence, procedures needs to be done in parts to avoid stimulating the patient that may cause fits in the patient. So the plan nursing care around the times when the patient or necessary treatment is given, this is done frequently when you are handling the baby. So you have to plan that in parts so that you do not disturb the patient frequently. The nurse should always with the patient in case of convulsion. So you have to open a convulsion chart to monitor the pattern of convulsion and also the frequency of the convulsions. Suction machine, oxygen cylinder, and tracheostomy set should be available. Suction machine to remove secretions after convulsions, and when someone is convulsing, it affects the respiration, so oxygen needs to be administered. To improve breathing, you may need to perform a tracheostomy on the patient so that you can improve breathing. Let us now look at the maintenance of the airway. The patient should lie in the lateral position. You can suck secretions from the nasopharynx. Okay, patient lies in the lateral position to avoid aspiration of secretions. And artificial airway or endotracheal tube may be inserted, and you are going to provide oxygen to the patient. Okay, let us also look at another aspect, which is feeding. A nasogastric tube may be used to feed the patient using an expressed breast milk. That is, you have to feed the patient 2 hours. Oral drugs are given through nasogastric tube, and in some cases, IV fluids have to be given in case of laryngeal spasms. You have to monitor intake and output. Let us now look at hygiene. You have to clean the eyes with normal saline and bath the baby daily, top and tail, okay, to prevent hypothermia. So you have to do tepid sponge and fever and change the linen when swallowed. You can turn the baby too early, feed the baby too early, okay, and mouth clean when necessary. Okay, let us now look at observations. Observe the frequency of the spasms or the convulsion, and you can observe for cyanosis, dyspnea, respiratory distress, and urinary output. You can observe for side effects of drugs and weigh baby weekly. Observe increase in the muscle rigidity, hypertensive reactions, and check vitals hourly in acute stage and 2 hourly when the condition stabilizes. It's also important that you take note of general condition of the patient. Okay, let us now also look at the care of the umbilical cord. And this is the route through which mostly the infection is going to come through to affect the baby. So if infected, you can use hydrogen peroxide, and you can use cool boiled water and keep it dry. Psychological care. You can explain the cause and the treatment of the disease, reassure the mother about the disease, that you're doing everything possible to help the patient. You can allow parents to be on the bedside, and they can also be involved in the care of the baby as they verbalize and tell you the concerns, so that you can make the necessary interventions. Let us now look at the other aspect of nursing care, which is position. We can place the baby in lateral position to facilitate drainage of secretions and prevent the tongue from falling back, leading to airway obstruction. Frequent change of position to prevent pressure sores is very, very important. So you need to have a turning chart on this patient. You need to have a feed chart on this patient. Okay? So you can handle the baby carefully if tracheostomy is made, so that you avoid the disconnection of the tubes, and there should be care of these tubes. Elimination. You ensure baby is passing urine by recording output and input, and also opening of bowels regularly. What information and education can we give to a parent who has got a child with neonatal tetanus? We can educate the parents on the disease process, positive agents, and the mode of transmission. We can educate the parents on the importance of hospital delivery. We can discourage the parents on the use and application of herbs or bits such as cow dung or umbilical stamp. We can educate the parents on the importance of immunization for children and vaccination for women of childbearing age. Okay, what can we do for this patient in terms of prevention? In terms of prevention, we can ensure clean delivery, clean hands, clean delivery surface, and clean umbilical cord and stamp care. Other things include immunization of pregnant women and women of childbearing age with tetanus toxoid. You can advise traditional bed attendants to board delivery equipment and to use new razor blades when cutting the umbilical cord. Alright, so that is it on our lesson on neonatal tetanus. Okay, so mostly to try to simplify things on the information education, okay, and communication, we talk of the mnemonic DRPHM. That is, we talk about drug adherence. Okay, R, we talk about review. P, we talk about prevention. H, we talk about hygiene. And N, we talk about nutrition. But it's important for you to note and not to be conditioned that when you talk about this mnemonic in given IEC, does not mean it is a blueprint that it should be used for all conditions. As we have seen in this condition, we are also looking at things, other things that may also come in. Okay, other things that may also come in, like immunization, okay, of mothers of childbearing age, immunization of the child. Okay, so these are some of the things that have to be noticed. So it's very, very important that we understand that neonatal tetanus is part of those conditions that may come because of sepsis in a child. Okay, so let's talk a little bit about sepsis. Neonatal sepsis. Let's define what neonatal sepsis is. This is the presence in a newborn baby, that is a neonate. Okay, this is the presence of, that is in a newborn baby, of a bacterial bloodstream infection such as meningitis, pneumonia, pyelonephritis, or gastroenteritis in the setting of fever. So we are saying neonatal tetanus is the presence of infection in a newborn, okay, that is less than 90 days after the newborn is born, with the presence of infection of meningitis, pneumonia, pyelonephritis, or gastroenteritis that sets up fever, okay, that will cause temperature to rise. So neonatal sepsis is divided into two categories. There's early onset sepsis and late onset sepsis. Early onset sepsis refers to sepsis presenting in the first 7 days of life, although some refer to early onset sepsis as within the first 72 hours of life. Then when we talk of late onset sepsis, this refers to presentation of sepsis after 7 days of life. Let us now look at some of the sources of infection in the neonates. Sepsis in the neonate period can be required. Prenatally, infection crossing the placenta barrier from the maternal side to the fetal side may be a source of infection in a neonate. During labor, inborn infection can be required, can be acquired by ingestion of infected amniotic fluid. So what we are saying is that sources of infection in a neonate may include prenatally, when the baby is still in the womb, infection crossing from the mother to the baby, so infection can be acquired. Then during labor, that is, inborn infection can be acquired by ingestion of infected amniotic fluids. Other sources of infection of the neonate include prolonged rupture of membranes, prolonged rupture of membranes during labor. Okay, so we have prolonged rupture of membranes always presents a risk as pathogenic materials are transferred from the maternal to the fetus, that is group B streptococcus or streptococcal most of the time. Now, postnatally, most postnatal infection may be acquired by cross-contamination from the infant's person, that is personnel and objects in the environment. Risk infant, other sources include risk infants to sepsis, like preterm babies, because they are actually very, very low immunity, they are fragile. Okay, so these constitute other risk factors to infant sepsis. Okay, so preterm babies, infant born following a difficult traumatic labor and delivery. What are the clinical features of neonatal sepsis? So in clinical features, because the bacterial infection, okay, we are going to have fever, apnea, dyspnea, convulsions, poor feeding pattern, reduced sucking, and diarrhea. We can also have other signs and symptoms like low blood sugar, reduced movements, slow heart rates, abdominal swelling, vomiting, jaundice, and full fontanelle. Okay, let us now appreciate the management of neonatal sepsis. Let's look at the diagnosis first. Blood for culture and sensitivity can be done to identify the causative organism. Urine for culture to isolate the microbe. Lumbar puncture, where cerebrospinal fluid is aspirated. This is to isolate causative agent, and it will show increased cells and proteins in culture because of the bacterial infection. ESR can also be performed to detect the presence of infection. Leukocytes count show increased number of polymers. History of chorioamnionitis and premature rupture of membranes may be some of the things that we can use for making the diagnosis. Okay, so when you're looking at management, mostly we start by discussing the diagnosis, treatment, and then we come to the nursing care. So now let's discuss the treatment of neonatal sepsis. Okay, so the treatment, you can commence treatment even before results are collected from the laboratory by giving benzopenicillin 50,000 international units, that is per kg body weight. You can give it IV or IM 4 times a day. This can be done with also an addition of another antibiotic, gentamicin, 0.6 milligrams IV or IM, given once a day. So now, away from diagnosis and treatment, let us now look at the nursing care. In the nursing care, some of the points that we can talk about include prevention. Under prevention, we are saying good antenatal care, because there's some infection that can come from the mother prenatally to affect the baby. We can provide safe environment for the newborn, clean environment, sterile equipment, and the likes to prevent infection, that is during delivery. We can discourage visitors with infections to attend to the baby. So within the nursing care, our concentration will be, we will look at the environment, how we can manipulate the environment so that we offer therapy to the patient. We are going to do the observations according to the infection that has been identified. We are going to ensure that the baby meets the nutrition requirements. We are also going to make a lot of emphasis on hygiene and infection prevention, since most of this infection is preventable. Psychological care also needs to be given to the mother or the caretaker. There is also need to prevent hypothermia and also give information education. So that is what we can say about neonatal sepsis. So to just make a little bit of a small review, we're saying neonatal tetanus or neonatal sepsis. We're saying neonatal sepsis. We started looking at neonatal tetanus. Now we're looking at neonatal sepsis. So neonatal sepsis, this is an infection that may happen in a neonate, and maybe meningitis, pneumonia, pyelonephritis that will cause temperature to rise. An infection affecting the newborn. Bacterial infection that may affect the newborn, that may be meningitis, pneumonia, or pyelonephritis, or gastroenteritis that may cause the temperature to rise. So neonatal sepsis is divided into two: early and late onset. Early, less than 7 days, or these 72 days, 72 hours, or late onset, which is after 7 days. Sources of infection, mostly it depends the stage. So it may be prenatally, during labor, or postnatally. But there are also other risk factors away from this that may include preterm babies, infants born following difficulties, traumatic labor, and delivery. The clinical features for the bacterial infection may include fever, apnea, dyspnea, diarrhea, knowing its gastroenteritis and the like. So depending on which causative organism has been identified. And it's also important to know that meningitis convulsion may be seen in meningitis. Okay, so low blood sugar can also be seen and all that. So in the management of this condition, we are saying when talking about management, you look at the diagnosis and the treatment. So management, you can do blood culture so that you identify the causative organism. Okay, do lumbar puncture. You can do a full blood count. You can, in the history, there may be cardiomyopathy. Okay, or premature rupture of membrane. Okay, so the drug choices includes benzyl 50,000 international units and 0.6 milligrams of gentamicin given OD, whilst benzylpenicillin give QID. So in prevention, also we are looking at according to stage. Okay, so we can prevent that. But apart from that, if it's neonatal sepsis, you can look at the environment, how you can manipulate it therapeutically. You can look at observations, nutrition, hygiene, and infection prevention. Okay, so now let's just look at another condition that may come because of sepsis, and that is ophthalmia neonatorum. Ophthalmia neonatorum is another condition that may come because of sepsis. So, by definition, ophthalmia neonatorum is a purulent discharge from the eyes of an infant within 21 days of birth. So, any inflammation that occurs in the eyes of an infant within 21 days of birth accompanied by discharge will be termed ophthalmia neonatorum. What are some of the possible causative organisms of ophthalmia neonatorum? So ophthalmia to do with the eyes, okay? Ophthalmia to do with the eyes. So there's a purulent discharge coming from the eyes within the first 21 days of birth. Okay, so causative organism here, condition is usually acquired during vaginal delivery, and causative organisms include Staphylococcus aureus, Streptococcus, Chlamydia, Haemophilus influenza, and one of the most common causes is Neisseria gonorrhea. Neisseria gonorrhea is one of the most causative organisms of ophthalmia neonatorum because of presence of sexually transmitted diseases. What are the signs and symptoms? So the baby is going to have sticky eyes due to the discharge. It's going to have past discharge. It's going to have congenital inflammation and lead eyes. The management here, you do the investigations to come up with a diagnosis by doing the swab for culture and sensitivity. Then the treatment will be according to the isolated organism. So local cleaning and swabbing of the eyes is very important with normal saline. Local antibiotic eye drops like penicillin can be given, chlorphenicol, gentamicin, and other systemic antibiotics can be given. Unfortunately, this disease of ophthalmia neonatorum may have following complications: conjunctival scarring, corneal infiltration, and blindness. So thank you. Today we have looked at neonatal tetanus, we have looked at neonatal sepsis, and we have looked at ophthalmia neonatorum as some of the conditions that may come due to sepsis in the child. So this is in a series of our pediatric lessons. If you have not watched other infectious diseases in the child, please, you can always look for those diseases that we have discussed. Like chickenpox, we have discussed those diseases. So you can have a look at those. So I thank you. Please, as you are going through the lesson, ensure you do write down some notes. It will help very much so that you consolidate the knowledge about this topic.